This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, she is a 75-year-old lady who has this tense black cataract and it is rock hard indeed. So in this case, I'm consciously making a sclerocorneal tunnel incision for fake emulsification. The idea is the sclerocorneal tunnel is much more forgiving as far as wound burn is concerned, and in the worst case scenario, if I'm in a situation where I need to convert, I can use the same incision to convert to manual small incision cataract surgery to extract out the nucleus. So that was the idea behind using a scleral tunnel incision. The surgery is being done under posterior subtenon's block. When I'm doing sclerocorneal tunnel, I'm very careful that I don't create a wide tunnel. It's just about 2.8 millimeter. The scleral incision is 1.5 millimeter behind the limbus, and the internal entry is also 1.5 millimeter into the limbus. So the only difference between this and a clear corneal phaco is that the angle of attack is slightly different, and we need to get used to this. The scleral tunnel phaco is slightly trickier and more demanding than a clear corneal phaco, simply because the phaco handpiece or the probe has to traverse a longer tunnel area before entering into the antechamber. And even the curvature planes are different than your clear corneal, where we have direct access to the antechamber. So these two things make it slightly tricky for a novice surgeon, but it is not going to be very difficult. It just takes a couple of cases for us to get used to it. The capsular staining is very critical in such eyes, and having an adequately large rhexis is of paramount importance because when you're going to break this nucleus into smaller fragments, we are going to induce some amount of stress on the rhexis margin, and it's going to be helpful for us if the rhexis is bigger. By that, we're going to induce lesser stress on the rhexis margin as well as the bag. So my strategy in this case is going to be the classical 4-quadrant divide and conquer technique. Once the superficial epinucleus in the cortex is aspirated out, time to change the settings to the sculpt mode. In the sculpt mode, my settings are 90% continuous torsional energy, aspiration flow rate is 12, and vacuum is 80. The bottle height is kept at around 80 centimeters. The nucleus is stabilized with my second instrument as the sculpting process is begun. So I start from the proximal rhexis end and reach up to the distal rhexis end. So please note that the left hand, which is having a blunt chopper or a scuke, is stabilizing the nucleus as I'm going in. After a couple of strokes, I have rotated the nucleus 90 degrees and a new trench is created. Now, because the nucleus is extremely dense and hard, you can see there is some amount of mechanical push to the nucleus which is happening in spite of using very high power. In such situations, it's important to stabilize the nucleus with the left hand. The nucleus is then rotated 90 degrees and the process of sculpting and deepening the grooves is continued. Whenever there is a mechanical push happening to the nucleus, there could be two reasons. Number one, we are using inadequate power for that density to the nucleus. The second more important one is, please note whether the sleeve does not get into the groove, then also the sleeve would be rubbing against the lateral walls of the trench, and that itself would be causing a mechanical push to the nucleus. So remember these two factors, and if the cause is the second one, the solution is to widen the trench. As we go deeper into the groove, it should allow both the tip and the sleeve effortlessly into the groove. The only price we're paying is we're going to have a slightly wider trench, which is not the best thing to have, but that does help to reach the most deepest part of the nucleus. So the sculpting process is continued. My goal is to reach 90% depth in all of these 4 trenches. So I'm closely watching on the horizontal fibers, and the moment they disappear, there is a slight change in the color. We can see the change in the color. Initially it could be a dark yellow or oranges, and now it's a very dark brown. And this is an indirect evidence that probably we are reaching very near to the posterior plate. The next challenge is to do the lateral separation maneuvers. I want to slow down here to show you. And the only secret here is to ensure that both the instruments, the phaco tip in the right hand and the chopper in the left hand, they have to be placed as deep as possible. The first attempt, it is not successful. I don't want to make any aggressive movement in the first attempt itself. So there's an unsuccessful first attempt. I go in much more deeper. Again, try one more time. And progressively the chopper is being placed in a deeper plane, and eventually we can see the crack happening. I have not used any excessive force. So it's more about getting the placement of the instruments as deep as possible. Then we don't require excessive force to crack it. Obviously, the most important thing would be to get the trench as deep as possible. The same maneuvers are being done in the other trenches. I am now switching to a longer Sinski hook. It's about 1.5 millimeter long. This helps me to reach the posterior plate much more effortlessly. The same principles of using multiple maneuvers of lateral separations are done, and eventually we could divide this fragment into two halves. The nucleus is rotated 90 degrees and the same maneuvers are continued. So now the most difficult part of dividing this dense nucleus into smaller fragments is done. Now it's very critical that we emulsify in a very controlled manner at the right plane so that the corneal endothelium does not take a hit. And using adequate and copious amount of OVD after removal of every fragment is a surefire way of minimizing the endothelial damage. So when I'm doing quadrant removal, I'm using the torsional energy in a pulse mode. It is set at around 80% energy, but in a pulse mode. And after every fragment removal, I'm going to add OVD. First, dispersive OVD, which is having chondroitin sulfate and sodium hyaluronate is used, followed by HPMC underneath it. HPMC is used in the vicinity of the bag and inside the bag, whereas the dispersive OVD is used more anteriorly towards the corneal endothelium. The idea is HPMC is less thermogenic and generates lesser heat, so it is placed in an area where we emulsify. And please mind, when I'm trying to emulsify the nucleus, you can see the amount of control which we have on these fragments. The fragment will be just dancing around the tip, never running around. And see my left hand. The left hand is always on top of the fragment, and it acts like a guard, preventing some of these fragments from jumping around and hitting the endothelium. The secret is to use the right amount of power. By that I mean we shouldn't use excessive energy. If you use excessive energy, there is a lens chatter which is going to repel the nuclear fragments away from us. And also note that tip position. I prefer to keep it sideways, especially when I'm using these Kelman tip, which is Kelman balanced tips, and I'm using torsional energy. This helps us to get access to the wider surface of the tip, and hence the engaging and emulsification happens much more rapidly. To achieve clear corneas post-op in such cataracts, the most important secrets are: number one, if we use phaco energy much away from the corneal endothelium, that is when you're doing sculpting and other things, it is really not so deleterious to the endothelium. Number two, emulsifying the fragments at the right plane in a controlled manner without causing any chatter is going to be much more meaningful as far as restricting any damage to the endothelium. So phaco energy or high CDE alone is not the cause for the corneal edema post-op. So it's mandatory that we understand these concepts very clearly. The most important cause for post-op corneal edemas in the first post-op day is turbulence in the antechamber and mechanical injury to the endothelium by these flying fragments. So if we can take care of this, definitely we can ensure clearer corneas on day one. And of course, number 3, more importantly, you have to use dispersive OVD very copiously. So after every fragment, as you saw here, I was using OVD, and if you can follow these principles, you are surefire to have a clear corneas in the first post-op day. And of course, the only price which you're going to pay is a longer surgical time, but that's worth it. I hope you found this video helpful. Thank you for watching.